Throughout your career, you will experience continuous changes in the standard of care. Some of the most common changes will involve the management of the cardiac arrest patient. Many have attempted to provide the most updated practices possible, but by the time most of these recommendations are published, they are obsolete. In this lecture, we will provide the most current evidence-based medicine available in cardiac arrest management. Your goal, our goal, is to have a heart save the brain. As a reminder, please follow your local SOPs or COGs regarding these practices. Current cardiac arrest standards include CPR should be done on a flat, hard surface. Always defibrillate VFib. Intubation attempts should be limited to 30 seconds. ALS actions are what save lives. Prioritizing epinephrine to improve cerebral perfusion. Asystolic patients have no survivability, and rapid transport improves outcomes. All these standards have been proven to be false. In the United States, an estimated 10% of cardiac arrest patients survive, with 90% never leaving the hospital. Are these acceptable rates? In cardiac arrest management, our goal is to save the brain. Neurological outcomes are key. ROSC, return of spontaneous circulation, does not equal brain cells. Current evidence-based practices involve the use of the following tools to increase survivability. First, continuous, uninterrupted CPR with a transition to automated compressions. Apneic oxygenation, the use of an ITD, heads-up CPR, delayed defibrillation for certain patient presentations, extended use of waveform capnography, and deprioritizing epinephrine administration and reducing the dosage amount. In the United States, the Utstein criteria is used to measure survivability from cardiac arrest. Utstein survival rates refer to the survival to hospital discharge of those cardiac arrest patients whose arrest events were witnessed by a bystander and that involved persons who had initial rhythms of ventricular fibrillation or pulseless V-tach. The Utstein formula for survival is widely recognized as a way of predicting survival from sudden cardiac arrest. The model employs three elements: medical science, educational efficiency, and local implementation. Current Utstein survival rate is about 27.9% for VFib and VTAC and about 4% for a Sicilian PEA. In 2016, Rialto Fire Department used these survivability tools to increase Utstein survival rate to 71%. Before implementing survivability tools in 2015, survival rate was 23%. By using an ITD and an automated compression device, chances of survival increased to 40%. Any two survivability tools gave an average of about 34%. Any three survivability tools, excluding defibrillation, increased chances of survival to 56%. By using all cardiac survivability tools, again, Rialto Fire achieved an Utstein survival rate of 71%. In-hospital and out-of-hospital studies have shown that performing active compression decompression CPR increases arterial blood pressure, increases coronary perfusion pressure, it lowers intrathoracic pressure during the decompression phase of CPR, and thus increases short-term and long-term survival rates. By using the appropriate device, the compressor may fully compress the chest to the necessary depth. This device also allows the compressor to have full recoil plus a little bit more. This enhances intrathoracic vacuum, it increases that preload to the heart, and it increases cardiac output on the next chest compression. The use of mechanical compressions requires training to reduce interruption of compressions. Most responders should be able to go from manual compressions to automated compressions in less than 20 seconds. Mechanical compressions also allows for higher rates of adequate compressions with decreased total hands-off time. Recent studies have shown that ROSC rates appear to be higher, 44.9% versus 23.4% using mechanical compression devices. In healthy people under ideal circumstances, PaO2 can be maintained at levels of greater than 100 millimeters of mercury for up to 100 minutes without a single breath, although the lack of ventilation will eventually cause marked hypercapnia and significant acidosis. As a result, apneic oxygenation significantly reduces the incidence of hypoxemia during emergency endotracheal intubation. These findings support the inclusion of apneic oxygenation in everyday clinical practice. During apneic oxygenation, the alveoli will continue to take up oxygen without diaphragm or lung movement. 200 to 250 mLs a minute of oxygen will move across alveoli. This will reduce the CO2 in the alveoli. Nasal cannula alone will fill the pharynx with high levels of FiO2. Apneic oxygenation is a safe and effective way to extend safe apnea time, the duration until critical arterial desaturation occurs. It is an adjunct to effective preoxygenation, and it is commonly provided using a nasal cannula in addition to a face mask. The impedance threshold device is a simple, non-invasive device that delivers intrathoracic pressure regulation therapy during basic or advanced life support CPR to improve perfusion. The ITD lowers intrathoracic pressure during the recoil phase of CPR by selectively restricting unnecessary airflow into the chest. This vacuum increases preload, lowers intracranial pressure, and improves blood flow to the brain and the vital organs. Studies have shown that the use of an ITD during CPR doubles blood flow to the heart, increases blood flow to the brain by 50%, and increases survival from out-of-hospital cardiac arrest by 25%. An article in the 2016 Resuscitation studied the effect of heads-up cardiopulmonary resuscitation on cerebral and systemic hemodynamics. It was recommended that heads-up CPR be maintained from the time the ITD is placed until ROSC is achieved. This 2016 study revealed that standard supine CPR increases arterial and venous pressure, thus reducing cerebral perfusion pressure. 30-degree heads-up CPR decreased intracranial pressure, thus increasing cerebral perfusion pressure. ROSC rates in Palm Beach County Fire and Rescue showed that an increase from 16% to 23% simply by using heads-up CPR. Though immediate defibrillation is necessary for bystanders, early defibrillation may not be successful. In prolonged patient downtime in out-of-hospital cardiac arrest, very fine VFib indistinguishable from asystole, end-tidal CO2 readings of less than 20 millimeters of mercury. The reason is these patients are acidotic and are less receptive to electrical therapy. These patients require high-quality CPR to increase perfusion, correct the hypoxia, and resolve the acidosis. If the patient meets the previous clinical findings, delayed defibrillation is preferred. A minimum of 5 minutes of survivability tools, continuous mechanical compressions, apneic oxygenation, ITD use, and heads-up CPR should be considered prior to the defibrillation. Immediate placement of end-tidal CO2 is the gold standard in cardiac arrest. End-tidal CO2 allows for assessment of perfusion, respiration, and oxygenation, all vital components of cardiac life support. Some key points. If the end-tidal CO2 that's greater than or equal to 15 millimeters of mercury and is trending upward, remain on scene. Provide all of the survivability tools for at least 30 minutes. You may use end-tidal CO2 to aid you in the decision to terminate efforts. If the end-tidal CO2 is less than 15 millimeters of mercury and trending downward, perfusion is poor for this patient. The use of epinephrine in cardiac arrest has been recommended in advanced life support since the 1960s. Evidence supports that administration is less than ideal. Epinephrine improves ROSC and short-term survival, but current evidence suggests that ROSC does not equal neurologically intact survival. In a vast majority of cases, epinephrine will start the heart, but it will have a negative effect on the brain. Evidence shows that epinephrine isn't a cure-all, yet we continue to use it. 2002, increased mortality. 2004, increased ROSC, no difference in survival. 2007, no difference in survival. 2009, 2011, 2012, increased ROSC, no difference in survival. 2015, it increased mortality. In 2018, the Paramedic 2 trial proved that epinephrine increased ROSC, but it also increased severe neurodisabilities in the survivors. Once again, epinephrine isn't a cure-all, yet we continue to use it despite the studies. So why epinephrine? Partially because of the alpha effects. It has peripheral vascular constriction. It increases aortic diastolic pressure. It increases coronary perfusion pressure, thus increasing cerebral perfusion pressure. Increased coronary perfusion pressure leads to blood flow to the heart, which equals ROSC. So why not epinephrine? Mainly because of the beta effects. It increases oxygen demand. It produces tachycardic dysrhythmias. It decreases microcirculatory flow, and it increases cerebral vasoconstriction. All of these lead to a significantly negative effect on the brain. Remember, what are we here for? Because we have to have a heart and save the brain. Why not epinephrine? Recurrent cardiac arrest will lead to ROSC with poor cerebral perfusion, which will lead to decreased neurological recovery. Ask yourself, we saved a patient, but wound up with a brain that doesn't work. Is that the outcome that you want? The Paramedic 2 trial should change the way that we look at epinephrine. The trial took 8,014 patients in a double-blind study. 4,015 of them received epinephrine. 3,999 received a placebo of normal saline. The study measured the rate of survival at 30 days, 130 with epinephrine, 94 with the placebo. It also measured the rate of survival with neurologically intact outcomes, 87 with epinephrine, 74 with the placebo. At the end of the trial, 39 patients that received epinephrine versus 16 patients that received a placebo had non-favorable neurological outcome. Out-of-hospital cardiac epinephrine administration resulted in a higher rate of 30-day survival, but no significant difference in favorable neurological outcomes. The spoon feed of the Paramedic 2 trial, more survivors in the epinephrine group had severe neurological impairment. So what does that mean? The use of 1 milligram of epinephrine every 3 to 5 minutes may be more harmful than beneficial. Epinephrine should be administered on a case-by-case basis, and lower doses of epinephrine may be more beneficial. Keep in mind that in the average cardiac arrest, it is not unusual to give at least 6 milligrams of epinephrine. So lower doses of epinephrine may be the option. One way is to look at shockable rhythms. By administering zero point 0.5 milligrams of epinephrine every 5 minutes on a timer, you will be giving at least 3 milligrams of epinephrine in a 30-minute cardiac arrest. In patients with non-shockable rhythms, 1 milligram every 5 minutes on a timer will give you 6 milligrams of epinephrine in a 30-minute cardiac arrest. So let's do a quick review of the 2020 updates for AHA adult BLS CPR. The basic steps in BLS: check for responsiveness, call for help and an AD, check for a pulse, scan the chest, begin compressions at a rate of 100 to 120, give 2 breaths, continue at a ratio of 30 to 2, and apply the AD as soon as it arrives. 2020 changes in ACLS cardiac arrest: administer epinephrine within 5 minutes of compressions. They added lidocaine 1 to 1.5 milligrams per kilogram as an optional antiarrhythmic and then repeat at half the dose. Old is new again. Lidocaine has been found to be just as effective as amiodarone. One takeaway from this is make sure that you max out your antiarrhythmic before moving to the next one. Do not alternate between the two. Though cardiac arrest care is important, post-resuscitation care is just as important. Traditionally, for first responders, ROSC has been an afterthought. You would get ROSC, and then you would ask yourself, now what do we do? Every cardiac arrest attempt needs to be prepared for post-arrest care. Post-arrest care starts during the resuscitation, and you need to have a transition to post-ROSC care in a seamless manner. Teamwork is extremely important in this pre-ROSC mindset. Every provider, every level has a distinct role. You need to have clear communication with good feedback. Only one person is in charge. That's the team leader. Everyone has a lane. Everyone needs to stay within their lane. Know where you fit in. Stay focused on your task. Next is check, check, check. What do surgeons, pilots, and engineers all have in common? Each of them has drastically improved success rates and increased efficiency by using checklists. You're probably thinking to yourself, a checklist? I don't need a checklist. I know all this. There are 4 major benefits of implementing checklists. Number 1 is that it increases consistency in the treatment. It reduces errors. It leads to improved coordination, and it increases clinical focus of the provider. Take a minute to review this pre-ROSC cardiac arrest checklist. Now take a few seconds to review this post-ROSC cardiac arrest checklist. It is important to note that a smooth transition from pre-ROSC to post-ROSC is vital to the survivability of your patient. A recent study reviewed the different parts of cardiac arrest, and they found that the minutes from the scene to the back of the ambulance were the most critical for patient survivability. Don't be in a rush to move to the unit for transport. A post-ROSC patient initially is very fragile. They may arrest again. They need immediate stabilizing treatment. involving an increase in their cardiac output. Wait 5 to 10 minutes after ROSC before moving the patient to the unit. Keep transport safety in mind. Take the mechanical compression device with you en route. Pull over and stop safely for any major interventions if need be. So let's be clear. What we have been taught isn't working. We have to stop doing what we have always done. We need to ask, in no uncertain terms, does every single thing I do in the cardiac arrest setting improve neurologically intact survival? If not, why do we not do it? There is no magical cure to successful cardiac arrest resuscitation, but the use of evidence-based medicine is key. Increased ROSC rates have been associated with the use of these cardiac survivability tools, and a strong QA/QI and training will increase these impactful actions. Thank you for your time.